Hello, and welcome to another episode of Boundless Body Radio. I'm your host, Casey Ruff, and today we have another amazing guest to reintroduce to you now. Dr. Kevin Gendreau is a returning guest on our show. Be sure to check out his first appearance on episode 265 of Boundless Body Radio. Dr. Kevin Gendreau earned his bachelor's degree at Boston University before completing his medical degree at Temple University School of Medicine in Philadelphia. He completed residencies in family medicine at Cambridge Health Alliance and Carney Hospital through Tufts University. He has also received an honorarium for prostate cancer research from the Dana-Farber Cancer Institute. Dr. Gendreau is a member of the American Academy of Family Physicians and the Society of Teachers of Family Medicine. His clinical interests include ketogenic diets and fasting, quality of life improvement, weight loss, dermatology, behavioral pediatrics, and adolescent medicine. His most recent book is called Fasting While Furious: How I Turned Anger and Sadness into Motivation for Weight Loss. In his spare time, he does volunteer work for uninsured patients, authors, and edits children's books, enjoys creative writing, and is engaged in early childhood literacy initiatives. Dr. Kevin Gendreau, what an honor it is to welcome you back to Boundless Body Radio.
Hi, how are you? Thank you so much for having me.
It is so great to chat with you. I got to meet you in person this year in sunny and warm San Diego. It was absolutely lovely there.
I
I
know,
I
so
don't
beautiful.
think I was expecting to see you. I was on the app and kind of playing around, and I can't remember whether I saw your name or not. But just looking up and seeing you kind of sitting towards the back with your laptop, I'm like, oh, it's Kevin. Awesome. It was so nice to meet you in person and catch up with you.
Same, and that's me hiding in the back of the class with like taking lots of notes on my laptop, not talking much. For some reason, I'm shy when it comes to things like that. Like a big conference with hundreds of people, I'm just like the shy one in the back. I don't know why.
That's really funny. I find that I absolutely love attending the conference. They're all amazing, and I love being social, and I love seeing all my friends, and everybody's ketogenic. So the energy level in the room is just so high. But also, I'm a bit of an introvert. I think you may have caught me on the very last day, like sneaking out the back door. I always sneak out like 20 minutes early without saying goodbye to anybody. I always feel
Yep.
bad about it, but I'm just like, I've had enough. I need to like chill down and go on a walk and like find something to eat. So I think you did bust me one of the days.
Irish exit. I love that. And also, like, I'm the same way. It's very hard to like sit still for 8 or 9 hours and like listen to lectures, even if the topics of the lecture are amazing and exciting and kind
Yeah.
of like in line with the things that you're,
Yeah.
practicing.
Yeah, totally. To just leave for like a 10-minute break and do a lap around the park or whatever was pretty great. I've been asking everybody, we met at that Symposium for Metabolic Health 2024. I've been asking everybody who's attended what were some of their highlights. So I want to ask you the same. What were some of the things that stood out from that, what I would consider a very special conference?
I think my favorite part is like not necessarily sitting in the lectures, although some of the lectures were phenomenal. Like I loved Tony Hampton and I loved Dom Diagostino, but it's the like social aspect of like the one-on-one stories that you hear from people and catching up with old friends who are in the community. Like I just love the anecdotes that I hear when meeting with people one-on-one. So for example, like I can sit next to someone who happens to be a social worker that works in Texas, and they'll share with me like how they even got into this space and how they personally lost 100 pounds just like I did, and they've been helping their clients from like a mental health perspective, and all of the benefits that you see from a mental health perspective with like low carb and ketogenic diets. And so that's my favorite part about the conferences. But I would say if I had to pick like a favorite lecture or update, it would probably be Dave Feldman. Like I always look forward to his lean mass hyperresponder data and how he's like really this citizen scientist and shares so much data. Like there's so much data that he shares that is unbelievable to me, where I have patients that I'm actively seeing who are losing all of this weight on low carb, just happen to have a high LDL, but like everything else about them is absolutely perfect. And in this field, it's like you could be pressured very easily by a cardiologist to start a statin when really actually your cardiac risk and your CAC score are better than any other individual in the entire practice. And so it's like so good to see the data and so good that I can share that with colleagues. I basically like take what I see in San Diego and bring it back to my colleagues in Massachusetts and it helps so much. And the day-to-day practice is really assisted by conferences like this.
That's so amazing. I use her as an example all the time. I was sitting next to her for most of the conference. My good friend Robin, I met her at one of the conferences. She's also just a layperson. She's actually a recent winner of the 2024 Fresh Start Award given out by Metabolic Mind and the Bazooki Group. So she just got a $10,000 grant to promote metabolic psychiatry, which is pretty cool. But she has been bipolar her entire life, medicated, half sedated for most of her life. For most of the kids growing up, was just exhausted from all these medications. And she accidentally kind of finds this weight loss diet that is called a, no sugar, no grain version of a ketogenic diet. She loses 60 pounds, feels amazing, starts deprescribing all her medications, is appreciating life a lot more, and is a lean mass hyperresponder. So it's one thing to say, like, yeah, like this question of high cholesterol or whatever is really, really important. But like when you talk about the patients that you work with, this is a real thing, and that's a real person who has to make a very scary decision. And like, you're right. Like, what if the cardiologist is so concerned with her cholesterol being ultra high? If she eats any carbohydrates, her bipolar comes right back, and her mood suffers, and her family doesn't really appreciate it. So it's those people that really need these answers, and people like Dave Feldman doing this research. It's incredible to actually like answer these questions and hopefully lead us down a path that can make people like that feel better about the decisions they're making.
Yes, because at the end of the day, like the decisions when it comes to this field, it's like up to the patient. Like as a doctor, you can provide all of the education and information. I can provide a certain set of education and information. Then they can go to their cardiologist who provides like a different set of information. And then the patient is left like trying to decide and decipher like what the next best step is. So it's just the more info, the better. And I love that. Like I'm not doing active research in this field. So that's why I appreciate it so much when there are people who do so. And then I can like share it with other doctors that I know in the community.
Yeah, that's amazing. You said one of the benefits too is like you get to meet some of the other doctors and people in the community, but also a lot of the lay people that are going through some of this themselves. And I just think, like, if nothing else, the question section where you're hearing questions from all these people, and the first in line is Dr. Hampton, and the second in line is a person on their weight loss journey, and the third person in line is Dave Feldman, and the fourth person in line is somebody who's maybe retired from medicine and they're just learning about this now. Like, it's so diverse, yet all the questions being asked are so good. These people are really, really smart with this stuff.
Yep. And then you also have people like Nayiri, who I think you interviewed recently. I don't remember if you were on her podcast or she was on yours, but she has type 1 diabetes. And it's like, it's amazing to hear someone like her's perspective on low carb, because I think a lot of type 1 diabetics think that they can't do something like this when really they can lower their like basal insulin rate so much and like fix their day-to-day symptoms so much and really control this disease. So it's amazing. It's just such a variety of perspectives and I love it. And I think I might go back next year. I'm like not sure yet. I don't have it booked, but I have a ticket for the actual conference. I just don't know if I'm going to be there virtually or in person.
Gotcha. Gotcha. Well, I already booked mine. He offers a discount, obviously, if you book it that day, and I always try to take advantage of it. Doug Reynolds does a great job at the conference. So I hope you can make it in person. I realize it's a much bigger schlep for you to get there to San Diego than it's for me, where it's just one time zone away. And you had a little bit of time to actually enjoy San Diego, right? Like you got to stay a few extra days, I believe.
Yep. I always do
Nice.
that. I go like a couple days early and stay a couple days later just so I have some time to like explore and
Yeah.
go to Old Town or Old City and look at it. Was just like it was so amazing just to like see the West Coast versus the East Coast, because the beaches that I'm so used to are all East Coast beaches and I really don't think you can compare them to the
Yeah.
West
Well,
Coast.
I don't know. I comparing California beaches to like North Carolina. I love North Carolina beaches, but yeah, where you are up in Boston is probably not a fair comparison to Southern
It's not
California.
the same.
Not the same. Oh man. Well, thank you for your thoughts on that. I think it's always fun to reflect on everybody's experience at these conferences that again are quite special. You have an amazing story, and it's been almost 2 years since you've been on our show. I'd love to hear your story again. Somebody can go back and listen to the full version on our first episode, which we did on episode 265. But can you remind us? Kind of what has happened to get you where you are and where you are currently with dealing with things like grief, for example.
Yeah, thanks for asking. So I am currently a full-time medical weight loss doctor, metabolic health specialist. But how I got here is pretty interesting. I was a 306-pound primary care physician, And when I was in primary care, this was like in my late 20s, I was training at Tufts, and I was diagnosed with type 2 diabetes. I had an A1C of 8.7. I had obstructive sleep apnea with a CPAP machine. I had high cholesterol, high blood pressure, fatty liver disease, depression. And really, I developed all of those diagnoses over the course of like 10 years. Like it was a very slow burn. I gained like 10 or 15 pounds a year every year after losing my father. And between losing him at such a young age to metastatic melanoma, he had skin cancer, and like the rigors of college and medical school, I just slowly but surely put on like way more than the freshman 15. And I ended up at 300 plus pounds. And so I was like, not practicing what I was preaching. Like I was a primary care doctor seeing patients who weighed less than me with problems not even as bad as me. And then, of course, I'm telling them, or advising them on what they should be eating or what they should be doing, and obviously not following any of that myself. And so when my sister was diagnosed with terminal cancer, this was an ovarian type of cancer called a germ cell tumor. I kind of switched my tune. And so instead of just like, rolling from 300 pounds to 400 pounds, I was like, I am faced with this decision where my sister is diagnosed with this cancer that's like incurable, and she has no choice but to undergo surgery and radiation and chemotherapy. And she was undergoing like stem cell transplants and like kind of investigative immunotherapy. And I was left with this decision, like I can continue to choose to go down this path, like continue to have uncontrolled type 2 diabetes, or I can smarten up and like make the right decision and change my life around in order to be there for her kids. And so I got into this field and really did a lot of research in metabolic health and hormones and like a hormonal biological approach to obesity myself. Went low carb, followed like a therapeutic carbohydrate restriction program, intermittent fasting, dropped 125 pounds, and then switched fields from primary care into medical weight loss. And that's kind of like what brings me to where I am today. And my sister ultimately passed away, which is horrible. But I would say the only, okay thing, I can't call it good, that came out of it is that like I transformed myself and have really helped so many patients out of that transformation, because I feel like I'm like inspiring and motivating to my patients since I've lived this myself.
Yeah. Wow. I don't know, man. I've gone through losing a parent to cancer, and it was terrible. It sucked. I still to this day kind of believe that to me, it looked like the treatments for cancer were really what did a lot of damage. I don't know what the cancer itself would have done in the end. And what I mean, obviously, we could have changed the diet in a different direction than we did at the time, and that was hard enough. But to like have that repeated in your life with your sister, and now you've got young kids involved, and like I don't know, that's such a heavy trauma. How are you doing with that these days?
Therapy is helpful. Also, I think having a therapist who like understands grief really well and understands like food addiction and eating disorders, binge eating disorder, night eating syndrome, like having a really well-versed therapist is really helpful, because it's not just a sounding board. It's like someone who can help you with cognitive behavioral therapy, and it's not just someone to like reflective listening. It's not just for reflective listening, it's for like treatment of these things. Like I know that I have, binge eating disorder, and I know that I have like addictive personality when it comes to certain foods. And so that's been so helpful in terms of grief. So I always encourage people who go through like the loss of a loved one at such a young age to definitely seek mental health counseling. I think I'm okay. Like I'm in a lot of a better place these days than I was when it first happened, because I was filled with like so much rage and, anger and sadness and sorrow. And I think accepting that like who you are as a person changes permanently when you lose someone that close to you is okay. Like I'm just not the Kevin that I was before I lost my father or my sister, especially my sister, because it was just so heartbreaking. And that's like okay, like it's acceptable to be a different person. I think I've been like hardened in a way that I wasn't before. Not that I'm not still kind of a softie, but I'm still just a different version of myself, and that's okay. And this version of me is very helpful for my patients in a way that I have more insight than I had before.
Yeah, yeah, I was reflecting on that as well. Thank you for sharing that. I appreciate it. I have seen many people over the course of, almost 2 decades of personal training and nutrition coaching, lose the amount of weight that you have lost. And I've seen them do it in various different ways. And I think for most people, if they've never lost that much weight and they need to lose that much weight, I think they can do it at least one time with calorie restriction. I think it's going to be really, really tough. I don't think you can do it more than once because of the damage that it causes eventually to the metabolism.
Because your basal metabolic rate lowers every time you restrict your calories and totally
Exactly.
breaks your metabolism.
Exactly. It's creating the perfect circumstance for that weight to come back on. I mean, my whole career when I was working back at the gym was using metabolic carts to measure metabolic rate on people. And that's exactly what we would see all the time is you're just going to take down your metabolic rate. So again, I think you can lose your weight once, but you'll probably cause a rebound. And it's very difficult to maintain. I've also seen other people choose a different route. They lose that much weight, but also they keep it off. They look like you look like you've never been a pound overweight in your life. I just saw you in person. You look phenomenal. You've been able to maintain this weight loss. What can you say about the way of eating and lifestyle that you've chosen that not only allows you to lose the weight, but also to keep it off? Like it hasn't seemed like it's been a big issue for you for years now.
Thank you. I honestly think that when it comes to things like disordered eating, right? Like, let's say the reason why you got to the place you're at now is you're 300 pounds because you binge a lot, right? You have binge eating tendencies. And part of that binge eating is like ultra processed food addiction. Like you are just like addicted to these foods. You get a little dopamine surge every time you have them. And then while you're binging, you feel better mentally. And then immediately after, of course, you feel like crap. That is like such a common picture that I see in patients. And it's really not that like binge eating is cured. It's just how often does it happen? Like, are you binging and splurging on some crazy food on Thanksgiving, like once a year, or like on your birthday, a couple times a year, once every quarter? Or is this like a 3 times a week kind of thing? Because if it's 3 times a week, it's like so disordered of an eating pattern that you're going to have no choice but to just slowly but surely gain the weight back and go right back to where you started. So it's really not that I've like cured these issues. It's that like the binge eating and the emotional connection to food and that like dopamine surge that I feel, it's just happening so much less frequently. It's like an occasional meal at a wedding or a birthday or Christmas. And the vast majority, 99.9% of the time, I remain low carb. I still do intermittent fasting. Even on days when it is like a splurge and I'm on vacation and I have a cheat, it's still like I'm cheating in a fasting window. Like I have a short eating window, or I'm doing like OMAD, 1 meal a day or something. So it's just like the baseline approach to the diet has changed. And this is like what I try to teach to my patients is there's this body type of insulin resistance. And if you have metabolic dysfunction where you have low HDL, which is your good cholesterol, and you have high triglycerides, and you have this larger waist circumference and an elevated HbA1c, hemoglobin A1c, and high insulin levels. If you have a picture like that, then your body type is just not going to respond well to processed foods, sugars, carbohydrates. And so if you go low carb, low sugar, increase your protein, healthy fats, and fiber, then you will like naturally fix that hormonal imbalance, naturally lower your blood sugar, or at least regulate your blood sugar, lower your insulin levels, lower your triglycerides. And that's your new default diet. So it's like this is the body type that you have, the cards that you were dealt, right? There's worse cards to be dealt in life. Like you could be diagnosed with MS or cancer or whatever. Instead, you're dealt a hand of cards where your body just doesn't process like rice and bread very well, because with rice and bread and pasta, you just put on weight so easily. And so this is so many of my patients. And I just explain it like that. Like your body type can't handle these carbs and sugars. And so your default meal plan needs to be meats and vegetables, which is not really that groundbreaking. It's kind of like an ancestral approach to eating.
Yeah, gotcha. Okay. Very well explained. I love that. I'm curious to know if you have the same response that I do. I I hate being as strict as I am, and I want to open myself up. Like I'm telling my clients about my Thanksgiving Day experience, and they're like, "Did you have a piece of pie?" And there was pie that I could have had, and I was like, I just didn't. I didn't have the pie." And it's like I'm sure I could have the pie, but I'll spend the rest of the day thinking about pie, and I'll be anxious about other things, and I won't sleep that well. What kind of penalty do you pay on that day of vacation when you go off?
Okay, that's a great question. So first of all, I think there's like two different types of people. There's the type of person who has a severe food or processed food addiction kind of thing, like the clients that Joan Ifland works with. It's people who have severe eating disorders or addiction where you have to almost take an alcoholic approach where you must abstain because you can like relapse into the unprocessed into the processed food addiction. And then there's the type of people where you can get to your goal, you can maintain really well, and then on a holiday, if you feel like having some mashed potatoes or a slice of pie, you don't like beat yourself up over it. You kind of just like forgive yourself and move on. But there's also some measures that you can take, and this is kind of like getting into the tips that I give patients. If you are, 99% on track, you're low carb all the time, you're always prioritizing protein, fats, and fiber, and then it's a holiday like Thanksgiving, and you want to have mashed potatoes and a slice of pie, then just like compensate for it. So know that you should have the protein, like the turkey and vegetables first, and then have the carbs last. So that way, if you're prioritizing the protein, fats, and fiber first and the carbs last, you're not having as big of a glucose reaction. Like you still may have some kind of glycemic response, but it's not going to be nearly as severe if you're prioritizing all the right food groups first. And then you can also compensate by exercising or just going for a walk after a big meal. And so there's ways to incorporate it where I have plenty of patients. I've had 3,000 patients for weight loss. If you are like at goal and you just want to have like a cheat day or a cheat meal, you can absolutely get away with it and be fine. It just depends on like your mental stability and your capability of doing that without flying off the handle. And I have both camps. Like I have plenty of patients who have to abstain due to like mental health reasons. And then I have plenty of patients who cheat once a week, once a month, and they have like no problem doing so because they have all of these compensatory mechanisms for cheating.
Gotcha. Wow. Yeah, I do get a little annoyed when people say, "Oh, it's the holidays. I'm just not going to really worry about this until January." And you sit them down and say, "You're talking about like 3 or 4 or 5 days, maybe, where you have a party or there's a meal. That's not even the whole day that you have that meal. And there's like 4 or 5 different things that you can do to mitigate it, to make it a lot easier on yourself. So you're not stumbling into January 20 pounds heavier, making it so much harder on yourself. If you maintained, like that would be a huge win by realizing exactly what you said. There's things that you can do. You can be mindful of those things, and it's only just a small percentage of a really difficult time of year, and you don't need to get too caught up in again, like full send on weight gain.
And what a slippery slope it is. Like it's Thursday for Thanksgiving, and then you're like, oh, screw it. I'll just start Monday. And then it's Monday, and you're like, it's just the holiday season. I'll start after Christmas. Then it's actually Christmas week. You're at a bunch of parties, and you're like, it's better to just start after New Year's. And not even New Year's Day, because I have parties on New Year's Day. Like you're literally going to put it off until you're dead. It's just crazy the way it snowballs.
Yeah, totally. Okay, with your story, I'm really curious between your own story and the people that you work with primarily with weight loss. Your first step wasn't low carb per se; it was cut out ultra processed foods. I'm wondering, like, why? Whenever I hear you talk about it, you make it seem so obvious. Like, oh, I'm just going to cut these out. You just went through your house, you took everything out of your counter, pantry, and the fridge, and you threw it away, and you just went back to the store and bought the things on the outside of the grocery store, and you just started eating that. That was enough to start kicking you off down the road. Eventually you found other things. But with the people that you work with, do they know that? Like, is it as obvious to them as it was to you that they need to stop eating those foods? If it is that obvious, is it just that dopamine response that you were talking about, that these foods are so addictive that people know that they're really not good for them, but they're addictive and people still indulge in them to the extent that they do?
Good question. I would say many patients, like maybe more than half, are like aware that cereal is not great for them and that they shouldn't be having ice cream and soda. The issue is the United States Department of Agriculture has said for so long, just have whole grains. So then they're like, I know white bread is bad. I should be having wheat bread. Or I know white rice is bad. I should be having brown rice. Or I know that regular pasta is bad. I should be having whole grain wheat pasta. So all of the swaps are really not doing them any favors because if you're insulin resistant, you're getting basically the same blood sugar spike, whether it's made out of wheat flour or white flour. So that's the issue is like, it's almost like a lack of knowledge of like it's not just ultra processed, it's also like what the ingredients are. And if those ingredients in the food, if it's wheat flour or white flour, it's causing almost the same glycemic response in the body. And that's all fine and good if you're like a size 00 and you've had a 6-pack since birth, then like, God bless, eat whatever you want. I would probably start my day with Oreos every day. Like if I had that body type and could get away with it, but I don't have that luxury because I have such an insulin resistant body type. So it's not about swapping for like wheat products or swapping for like the lower carb version of whatever bread you're thinking about. It's like you actually have to like figure out how to get rid of the processed crap. I don't know. I think people know, but they don't know the full picture of it. So it's like they have some knowledge, but not the full knowledge. Or it'll be someone like my average patient is 53 years old. That's the average person that I see. And it's like at some point in a 53-year-old's life, they've done low carb. Like this person probably did Atkins 15 years ago, right? And they're like, yeah, I did Atkins. I dropped 50 pounds, but then as soon as I started eating normally again, and I'm
Love
like,
it.
normally again is 244 grams of total carbohydrates per day. That's like the standard American diet is 240 something carbs a day. So normal is not good because normal and average is like obese now.
Yeah, very well explained. Yeah, I always wonder whether it's an awareness issue or just like these foods taste that good kind of an issue. And yeah, you're right. It must be like a 50-50 thing. And I get it. Like if I start eating those foods, I have a very difficult time stopping. So for me, it's best to abstain and just stay away from those foods. And I know another method that you used for your weight loss is fasting. It's kind of interesting fasting itself. Like it seemed like we were talking a lot more about fasting a few years ago, and now it doesn't seem like we talk as much about it. But when I ask people about it, they're like, "Yeah, I still do it." But it's funny how it becomes almost an afterthought. Like it's really quite effortless after a while of eating this way. You just kind of seem to naturally want to fast anyway. Has that been your experience with fasting?
Yeah, what happened with me was I was like 306 pounds. I started doing low carb, which really I didn't even call it low carb at the time. It was just like I got rid of processed food. It was like closer to a Whole30 diet. I just didn't eat anything processed. And it happened to be that everything processed has sugar and carbs in it. So, anyways, I went lower carb. And then about 75 pounds in, like after I lost 75 pounds, I read Jason Fung's book, The Obesity Code, and then I started, that's like the typical story. And then I started intermittent fasting. But it's the reason why I even read that book was because after going low carb and prioritizing like protein and veggies all the time, I realized that I wasn't as hungry and I would just like skip breakfast. But like the classic school of thought, like the thing that you're taught, even in medical school and nutrition classes, is you're supposed to eat breakfast. So I was like, but I'm just not hungry for breakfast. I just want to eat when I want to eat. And I don't want to like force myself to have 5 small meals a day. So I naturally started fasting and I was eating in like a 6 or 7 hour window. And then I read like the 6 or 7 hour window was just like naturally occurring. And then I read the obesity code and I started making it a rule with myself every day where I would just eat like lunch and dinner. And I pretty much always stayed in like a kind of 12 noon to 6 p.m. eating window. And then it kind of like restarted my weight loss. Like I was stuck a little bit after 75 pounds. I was just plateaued. Like that was my, my body's set point at that point. It was like 235 pounds and started fasting and it helped me get rid of another 50 pounds. So it was very helpful. And I still do it to this day. And it's funny that you say that people don't talk about it as much. I think it's because we know it's helpful. We've known that it's helpful since like the days of Plato and Socrates. And like people have been fasting religiously for literally millennia. And it's not really groundbreaking, right? Like it's like someone had to say it, right? Like Jason Fung had to write it in a book and people need to read it to like understand that. But nothing about it is like shocking or surprising. The only part about fasting that I've never really like dabbled in because I'm not really good at it because I get hungry and I have cravings is like extended fast. Like I've never done 72-hour, 5-day fast or things like that. The most I'll ever do with myself or with patients is just like one meal a day, sometimes fasting for 24-hour periods, but we don't really like monitor patients on like a weekly basis or multiple times a week. It's like more like a 6 to 8 week interval schedule. So to do more extended fasting, I don't like generally recommend it to patients of mine.
Gotcha. Okay. Yeah, I kind of do the same. I'm not a huge fan of those extended fasts. I've seen people get incredible results with them. I've got kind of some questions about it myself. I don't tend to do them either. And it's funny, like I was brought up in the Mormon faith, and based on what they teach, like the first Sunday of the month is called Fast Sunday, and you're supposed to go a 24-hour period without eating. And oh my goodness, the most miserable you would ever feel in your entire life going 24 hours. And now I think about today, and I'm like, I'm 22 hours fasted right now. I feel fine. I'm not hungry at all. It's totally different. And on that note, like, why do you make sure that the people you're teaching fasting to, you're making sure that they change the diet first?
Oh, well, I think there's been some studies published in the New England Journal of Medicine that show if you just do like a calorie counting diet with intermittent fasting and eat the same crap but less of it, intermittent fasting is like pointless. So it really only seems to be useful in terms of like my own anecdotal experience if low carb is in place first. So it's like the biggest thing that I discuss in the first visit with patients is reducing carbs, reducing sugar. Usually I say to like less than 40 to 50 total carbohydrates per day. And if they want to do net carbs, they can do that, but it's like 20 or 29 grams of net carbs. And then at some point in the future, I usually like leave it open. I cover like the tools, like the potential tools that can be utilized to help assist with weight loss. The base change being low carb, and then these other tools can be added in. And one of those tools is intermittent fasting. And so about a quarter of my patients do it, and it can be like super helpful. And it's like kind of always on the table. And yeah, patients do love it. And I think if it works with your schedule, and if you're like not someone who's hungry after 22 hours, then it's like perfect for you. But then I also have patients that are low carb, eat 5 meals a day, and they're fine because they're eating the correct food group. So it like doesn't really matter. Even if they want to do 5 small meals, it's like I'm not going to push them into doing intermittent fasting. It's like whatever works with their schedule. Just like how sometimes I have carnivores and sometimes I have vegans. Like there's no agenda being pushed. It's like protein can be protein. It's lupini beans and peanut butter and tofu if you want it to be. And then protein is also steak. So I kind of see anybody who wants to see me, whether they're a vegan or a carnivore.
Yeah, that's really helpful. I just appreciate that there's an order to it. You know what I mean? Like, don't worry about fasting. It's not on the table until you change the food, and focus first on getting really full on the good things, the fats and the proteins. Just eat a lot of that, whatever you decide to eat, whatever, fits your thinking and your taste, whatever, carnivore, vegan, and everything in between. Get really full with your foods. Then we can talk about fasting. And then it's even like exercise. Like, don't start with exercise.
Yes,
Wait
yes.
until you have tons of energy when we can't stop you from wanting to exercise. Like, don't start with that. Don't think that's going to be the thing that's going to kick off your weight loss. It's out of order. You have to do those in the right order.
Yes, one of the most common quotes that I hear is, I'm doing everything right. And it's like when I first meet a patient, they're like, I'm doing everything right. I don't know why I'm not losing weight. And everything is like working with a personal trainer, no dietary change. Taking Wegovy, no dietary change. Intermittent fasting, no dietary change. So they're like doing all of these interventions and their diet has not changed. They go work with a personal trainer, leave and eat pizza. They're like intermittent fasting, but as soon as their window is up, ice cream. It's like you are like the base change has to be diet. These other things are amazing. Like no one's, I'm never going to be a doctor that says like don't work out. It's just like don't waste the workout is basically what they're doing. They're like working out just to be able to eat ice cream and maintain their current weight, which is probably, 300 pounds, which what's the point?
Yeah, totally. Okay, well, that was a great segue because I really wanted to get an update on weight loss medications. Last time we talked a little bit about weight loss medications. It's something that you deal with and you use with your patients, which I think is wonderful. I think I could be wrong about this, but I'm pretty sure you were the first person to come on this show back in 2022 and tell us about GLP-1 agonist drugs that were, I mean, they've been around and been around, especially for like type 2 diabetes, but we're just starting to kind of get a little bit more attention. And now they've gotten a lot of attention. You've had a lot more experience working with them at this point. Um, can you give us like a bit of an update on how things are going? What things you see could be good, could be bad. And maybe we should start out by even explaining what these things are and what they do.
Sure. So GLP-1 agonist medications. So GLP stands for glucagon-like peptide. Basically, these medications are peptides that agonize in different areas of the body and work to help suppress appetite. So they work in your brain to decrease overall cravings. They can help with cravings for carbs and sugar, overall appetite suppression, the lower hunger levels. They work in the gut to slow down gastric emptying, which can help you feel fuller quicker. And then they work in the pancreas directly to improve insulin sensitivity. There's also GIP agonists that agonize GLP-1 and GIP receptors. So GIP stands for gastric inhibitory peptide. Those dual agonist receptors are like Mounjaro, Zepbound, and those are also known as tirzepatide. So we have like Wegovy, Ozempic, semaglutide, and that's GLP-1 agonists. And then you have the GLP-1 and GIP agonists, the dual agonists, which are newer. And so these medications are once weekly injectables that you do yourself. They're like subcutaneous. And so because they work in all those different parts of the body, they're showing like amazing results when it comes to weight loss. But that definitely has like a caveat. So when it comes to my like medical opinion as a weight loss doctor, you know, what is the best medication for weight loss on the market? Definitely injectable weight loss drugs are the best. If you compare them to like stimulant drugs like phentermine that have been out for 30 plus years, these injectables are like changing the game. People are losing like 10, 15, 20, 25% of their body weight. But they're not all perfect. Like they come with a slew of side effects. There's like risks to anything. They're extremely expensive. And so about a quarter to a third of our patient panel actually takes the medications. And if I have a patient who comes to see me as their weight loss doctor and their first thing is like, the first thing out of their mouth is like, hi, my name is Charles. I need Wegovy. It's like, this is not going to be a good therapeutic relationship. Like the priority needs to be like, hi, my name is Charles. I want to better my health. I want to drop 50 pounds. I want to reverse my diabetes. Because the best part of my job is de-prescribing drugs. Like I love when people lose 75 pounds and no longer need medicine to lower their blood pressure. I love when people drop 40 pounds and don't need a statin anymore because their cholesterol is amazing and their triglycerides are lower. I love when people come to me with diabetes and now they no longer need insulin because we were able to taper them off since they lost so much weight. So that's the type of like client and like doctor-patient relationship that I really love. And I'm just like, I actually say this during my first weight loss seminar with patients is like, I am not a vending machine. If you're just like, hey, nice to meet you, give me Zepbound, it's like, that's not going to work with me. Like these medications are specifically a tool for a certain type of patient. And if a lot of things are not in place for them to work, then they're like not going to be helpful for you. So if you're the type of person who's going to take Wegovy and eat pizza, bagels, and ice cream all day, like it's not going to work out because you're going to be sick all of the time. You're going to have severe acid reflux. You're going to have bloating, GI distress. You're going to lose muscle mass, not like actual body fat. And so that's what I mean when I say they're not all perfect. You know, they're not this like miracle drug. They're amazing and they can do great things, but like with a caveat of like you have to put in the work yourself.
This is probably a way over obvious question. I'm just curious for that person who comes to you for the vending machine, they just want the pill, and you say, hey, this isn't going to be a good relationship. Is it terribly difficult for them to find a doctor who would be that?
Oh my God, they could literally leave and on their phone walking out of the building, they can find
Okay.
like a nurse practitioner in like Alabama that'll just call it in for them. So it's
Okay.
not the people that I work with, like it's, I don't know. I do have that happen and sometimes I do suggest that they see someone else if that's how they're treating it. It depends on their attitude about it. Because maybe they're saying that and they're just not understanding that it's a dietary change as well, you know, like that they have to put in this extra work. They just might not know any better. And
Yeah.
so I'm like, I'm willing to like put in the work and teaching them. And that's why the first time meeting me is like it's like a course seminar that's 90 to 120 minutes, which we were joking about sitting through classes earlier, but it's like I do that because there's so much to teach when it comes to metabolic health and insulin resistance. And if you're not taking a dietary approach first and foremost, then like nothing that we do is going to work. Like no other tool that I can reach for is going to help if the diet's not on point.
Gotcha. Okay, that's really well explained. And check me on this as well. I believe that the dosages for type 2 diabetes, those medications have different names. It's the same drug, but it's just a much smaller dose, and it works. You mentioned all the places that the drug works at. I believe that the type 2 diabetes drug dosage works more in the brain, and that the weight loss drug transfers more of the effectiveness in the gut where it's actually slowing things down because you're ramping up the dosage over time to be the highest kind of dose that somebody can tolerate. Do I have that correct?
So that's not quite accurate. So basically it's Ozempic and Wegovy are both semaglutide. Wegovy is just one little tick higher than Ozempic in terms of dosing. So Ozempic's the max dose is 2.0 milligrams. Wegovy goes up to 2.4. So it is a little bit higher for the weight loss, but it's actually the same molecule. They're both semaglutide. And then tirzepatide is the one from Eli Lilly, and that medication also once per week is marketed as Zepbound for weight loss and Mounjaro for type 2 diabetes. And they actually have the exact same dosing. It's like 2.5, 5, 7.5, 10, 12.5, and 15. And those medications are a bit stronger than Wegovy and Ozempic. Like there's more weight loss in clinical trials. With the caveat of in clinical trials, they don't do low carb, they do calorie counting. So the trials are
Okay,
not exactly
gotcha.
how I would set them forth.
Yeah, yeah. Okay, okay. Thank you for explaining that. And let's start with kind of the good about this. I didn't know that you could lose that much percentage of somebody's body weight, like 10, 15, 20, 25%. Is that something you see also, not just at trials, but that's something that you notice?
So in our patients, like in my clinic who are on GLP-1 or the dual agonist with the GLP and GIP, we see an average of 20 to 30% weight loss because of how strict I am about diet.
Gotcha.
So that number is just slightly better than the patients who I see who are doing it without medication. The patients that I see without medication are still losing an average of about 25 pounds every 6 months and almost 50 pounds in a year. It's just that the medication helps to, like in patients who have issues with food addiction or binge eating, it can like help with the food noise. So it kind of like unlocks the ability for those patients to lose weight a little better because they can adhere to the diet more. So I really am utilizing these medications as like a way to adhere to a diet rather than like this like miracle drug that you see on Facebook. I can't believe like the stories that you see on social media where people are like, I eat whatever I want and I'm down 75 pounds on Ozempic. Like it makes me crazy because I know in clinical practice, I have plenty of people who take the drug and eat like they've always eaten and they lose 4 pounds. Like nobody's coming to me to lose 4 pounds, and probably the 4 pounds is muscle.
Wow. Yeah, I hear those commercials all the time as well, and I just want to throw my phone across the room or whatever. Oh
Yeah.
man. Okay. And then you also hear that these are lifetime drugs. Once you start, you're on them forever. Once you stop, you gain a bunch of weight, so you have to continue. Have you had success with people that have wanted to eventually get off of these, as far as like tapering them down and getting them off of them successfully?
Yeah. So what's interesting is in all of the clinical studies and trials on these injectables, they do like basic calorie counting, right? And when you do basic calorie counting, people are like, well, I can still eat pizza, but only one slice. And I can still eat sandwiches, but only half. And I'm still going to have chips, but only half the bag, right? So everyone's just doing the same diet they've always done, which is the standard American diet of 6 to 11 servings of grains all day long, but they eat smaller portions. As soon as you get rid of the medication, people gain all but 6% of their body fat back because they never fix their diet. So we take this like super important hormonal like biological approach to weight loss where it's like you have insulin resistance, you have to prioritize protein, fat, and fiber whether you're on a drug for weight loss or not. And then if you ever want to, remove the medication, if you're on Zepbound for a year and get to your weight loss goal, you're actually able to taper off that medication if you remain low carb, high protein with a good exercise regimen, possibly an intermittent fasting plan. It's like absolutely possible. But I will say it's probably 50-50 where like half are able to do it no problem and half struggle because as soon as you get rid of the medication, the food noise comes back and they're like, this is how I felt before and I did not like thinking about food all of the time. So it's
Gotcha.
like a risk that you're, taking. Just like when you sign up for these medications, you're signing up for all the potential side effects, especially if it's something that's just like being called in, right? Like through the internet, like you meet a nurse practitioner for 5 minutes and they're calling in Ozempic, like, or, semaglutide, just like the generic version that's compounded. You're signing up for all of the risks, all of the benefits, all of the potential side effects without really understanding them wholeheartedly. And so that's one risk is like, what if you stop the medication and you don't like the way that you feel off of it? Although
Got
right
it.
now it looks like in longer term studies, like we have a 4-year Wegovy trial that's out there that shows clearly people can take it without increased risk of any kind of like coronary artery event or cancer risk for a 4+ year period, which is really good that we have that data now, because now I can share that with patients and say, look, we have 4+ year data that says nobody's getting any kind of crazy cancers or anything from these medications. They're getting muscle loss. There's cases of pancreatitis, but like at least we know long term there's no increased risk of cancer. It actually looks like there's a decreased risk of colon cancer and possibly other types of insulin-mediated cancers. So
Interesting.
the jury's still out on like long-term use. Like we don't know about Wegovy 10+ years out because we don't have like a study showing that.
Yeah, gotcha. I didn't even know we had one that was ongoing for 4 years. So that is kind of helpful to kind of start to parse out some of that data. Let's talk about some of those other side effects or some of the weird terms you hear, weird stories you hear out there. Again, this is not the people necessarily that are addressing diet, lifting weights, hopefully focusing on protein, all those things we'll talk about here in a minute. But like the people that are not really changing the diet, you hear Ozempic face, you hear pregnancy stories that are quite weird. You've written about that on your Instagram. You hear about Ozempic babies. I don't even know what that is. And if those two things are related, the babies coming out like Ozempic resistant or something. Um, yeah, there's so many interesting kind of like, again, side effects, or I think most people understand the Ozempic face is that muscle loss. What things concern you as far as some of the side effects, again, especially when somebody is not really addressing their lifestyle?
Okay, so I will go over like all of the most common side effects that I review with patients before we're going to be starting a medication like this to assist. Because the medication works in your gut, it can cause nausea. Because it slows down gastric emptying, it can cause constipation, which it often does. So nausea and constipation are like the #1 and #2 most reported symptoms with these injectables. Because it works in the pancreas, it's associated with pancreatitis. Because it slows down the gut, there's been cases of gastroparesis, which is like a slowing down of the stomach. So everything kind of slows down, including your stomach. And so pancreatitis and gastroparesis are both two of the like warnings before taking the drug. So if you've ever had pancreatitis or gastroparesis, it might not be wise for you to be on a medication like this because it can worsen those problems or like bring it about again. Like say you had pancreatitis 10 years ago and no one knew why. It's called idiopathic pancreatitis. It's probably not worth taking a drug that will hit your pancreas so hard, because what if it causes an episode again? And pancreatitis can be deadly. And then there's multiple endocrine neoplasia type 2, which is one of the black box warnings. And that's a very rare genetic form of cancer that runs in families, and medullary thyroid carcinoma. So you can't have a personal or family history of medullary thyroid cancer. So those are all of the like black box warnings that I'm asking people before we would even start a medication like this. And then constipation, nausea, muscle loss are all like considerations of what to deal with. And then there's the just like reported symptoms of when I eat bad on Wegovy, what happens? And this is like, if you do binge, like say you have 6 donuts, or say you just eat a whole pizza on Wegovy, you have like the consequences of that. And so because this medication is slowing down your stomach and trying to regulate your blood sugar, and now you've eaten this ginormous glucose load, you're going to have issues. And the most common issue is like GI. Like people will get abdominal cramping, bloating, diarrhea, more severe constipation. I've even seen a case of pancreatitis after binging. So there was a case in my clinic of someone who like after eating a lot of Halloween candy, they like binged all day on Halloween, and they were on the highest dose of Wegovy, ended up in the hospital because they have these side effects that are associated with the medication. And it's like they probably would have felt like crap anyway, right? Like if you're on Wegovy or one of these injectables and eating Halloween candy all day, you're going to get sick. You would get sick without the Wegovy, but this person was hospitalized because of the medication. And so it's like the idea behind it is you're taking the med and you're hopefully not craving that stuff as much, but it's still possible to eat through. So you know how people will get like bariatric surgery, and sometimes there's cases years later where they like ate through it and like gained all their weight back. We're seeing like similar cases where you can like eat through quote unquote Ozempic or eat through Wegovy. Like you can take the med and just like somehow still eat the same foods, and it just pushes you right back to where you were when you started.
I see. Wow, I've never thought about that. Another thing that I've heard, I'm not sure if this is true, is that I've heard of people that the food and the constipation is so severe, the food slows down in the digestive system so much that it stays in there for like days, and people are
Yeah, that's true.
belching, and it is tasting like burnt garbage or
Like
whatever. Like,
sulfur burps, yeah.
yeah,
That's part of the gastroparesis thing, like when your stomach slows down. And this is why if people are undergoing anesthesia, they have to stop the medication like 1 to 2 weeks ahead of time because you don't want retained stomach contents if you're supposed to be fasting for a procedure. Oh, and then we didn't talk about Ozempic babies.
what is
I
that?
have lost track of the number of patients that I have who have gotten pregnant on these medications. And I laugh, but it's like I include a huge warning to any female patient of childbearing age. If you are starting this medication, we know that it increases fertility. And I say increases and not improves because, like, what if fertility was not desired? Like, you may be 47 years old and absolutely not wanting to get pregnant, and yet it's happening. And so we don't really know the long-term consequences of that because these medications can cause maybe like growth restriction in the fetus, right? Like, if there's less nutrients coming into the mom, then maybe the fetus is getting less nutrients, causing growth restriction. So it's not advised to get pregnant while on these medications, and yet fertility has increased. So people are getting accidentally pregnant. And I've had quite a few patients who think they're going through menopause because they're in their late 40s, early 50s, and it's not menopause, it's a baby.
Oh my goodness. Yeah, I heard you on a shorter podcast kind of talking about this. And I think you had a 51-year-old woman who was having twins. Oh my goodness. Like, is it,
Yep.
is that,
It was
I
actually
mean,
a former patient of mine from primary care. So now
did
she's
she
just
deliver?
pregnant. Yep.
And it was
Fine,
everything.
healthy babies.
No way. Wow.
But like that should not be an endorsement of getting pregnant on one of these medications.
Wow.
That was
Well,
kind of
good
just
for
like a
her.
miracle, I
Congratulations.
think,
That's, yeah,
like
that's, I mean, you're going to be, what, you're going to be 69, 70, heading into high school graduation at that point. Like,
I know.
that's awesome.
It was
That'll
not
keep her young.
planned.
Yeah, that'll keep her young.
Not planned. It's because,
Interesting.
I mean, it really wasn't known. Like, this is like a more recent thing that they're realizing these medications increase fertility. The major reason why that happens is because of weight loss. Like, we know that losing body fat increases fertility. That's like a no-brainer. But it's also because it dials down insulin resistance. So if you have a very severely insulin resistant body type with PCOS and you take a medication like Wegovy or Zepbound and you're like actively losing weight, then your period can normalize, especially if you're following low carb along with it. Your period starts to normalize, and then you have a body where you thought you could never get pregnant because you have severe PCOS, severe insulin resistance symptoms, and now all of a sudden you're fertile. So that's what's happening.
Wow. Okay. Good to know. In your experience, having worked with these and also having changed lifestyle, like I think the weight loss would be more effective, obviously, if somebody's doing low carbohydrate. I think it would be more effective if somebody was doing some type of strength training to help maintain muscle mass. I've seen people take these drugs and used an in-body. I believe you use the same to test
Yeah,
people
yeah.
and use muscle mass, and I've seen it be stable or even like the increase while they're on it. So I've seen those happen. For the side effects, if somebody is changing the lifestyle the way that you are wanting them to, and they're taking the drugs, versus the people that are not doing anything lifestyle wise and experiencing the side effects, do people that you work with tend to experience less side effects?
Do you mean side effects of what?
All the things that you mentioned, like if somebody,
Are
how I
you
phrase
saying
this,
if they're following low carb versus calorie counting?
yeah, like you, all the things you mentioned, like the gut slowing down, the constipation, the discomfort, the nausea. If somebody changes their diet and they're working on their lifestyle and they're taking these drugs, do they tend to notice less of the side effects as well?
Yeah, so that's so interesting. I think if they did a study with like keto or low carb with intermittent fasting along with one of these injectables, I think they would see like the rates of reported side effects be a lot lower because the body is like following, like your insulin resistant body type is basically following the diet that's most appropriate for it. So then the side effects are like mitigated. Like you're not going to have this suffering that you have because the medication is not like trying vigorously to lower your blood sugar while you are eating carbs and sugar. So in my experience, I do still have patients having lots of side effects, but like I think they'd be way worse if they were doing calorie counting. And I can't even think off the top of my head of a single patient that I've seen in the last 2 years who just does calorie counting and nothing else. Because I feel like it doesn't fit the vibe of the clinic. Like we're a metabolic health clinic and our focus is so much on lifestyle change. And so if someone came to me and they were like, I just want to do 1,200 calories a day. So I'm going to start my day with whole grain English muffins and I'm going to have half of a sandwich on wheat bread for lunch. I'd be like, this is not the right clinic for you.
Yeah, seriously.
I mean, they could say that, but then I would do my best to try to convince them to eat like a diet that's appropriate for their body type.
Yeah. Okay. Yeah, that makes a lot of sense. It's kind of why I asked the question. I think of it. We have to remember GLP-1 is something you already have in your body, like it's already there. And so if
Yes,
you're
and
eating
there's like natural ways to agonize those receptors too.
exactly, yeah, exactly. So I'm thinking about what you mentioned earlier with Nairi trying to control her type 1 diabetes. You can control type 1 diabetes by eating a lot of carbohydrates and then taking a lot of insulin, be dealing with huge, huge, huge swings and a lot of medication, or you can eat the proper way and have this tiny little rise in blood sugar and use a tiny amount of insulin, you're using less medication. So to me, it would make more sense that somebody be more likely to have lower doses, less side effects, feel much better, have way better results when they're changing the diet, getting the natural effects, and using the drug as just this little boost. Like I would think everything would just kind of like even out way better, have way less side effects, that sort of thing.
Especially people who really need it. Like, I think there's people in this space of low carb, keto, like, you know, when you go to a conference like Low Carb USA, right? There's people who go there that are very much staunchly anti-drug. Like they will, like they're very anti-statin, they're very anti-GLP-1, they're anti-everything, right? And like, trust me, I know there are problems with pharmaceutical companies, right? But I also have seen anecdotally so many patients with like severe eating disorders have a freedom that they've never had from that eating disorder. I've had patients who are alcoholics, patients who are addicted to drugs, and they're like doing so much better on doses of these medications. And so there's just like no denying scientifically that they are helping a large chunk of my patients. I still go back to lifestyle as like the core, and I still have hundreds and hundreds and hundreds of patients that are doing just lifestyle changes, intermittent fasting, working with personal trainers. Like that is all so important, and it's not to minimize that. It's just like we have this extra tool, and I think it's important being like an MD and being in this field to like utilize a tool that's available, especially when it's this much of a game changer.
Well said. I think that's a great way to think about it. Remembering that every patient is a person and a story, and they've got different, you know, a whole range of things that they're willing to do or not willing to do, and things that will work or not work. I remember a panel that was done by, I believe it was Low Carb Denver in 2023, when it was a group of cardiologists doing their typical kind of debate about statins, statin use, and one guy saying there is no good use for a statin. Statins suck. They're the worst. They're terrible. And the next guy is like, dude, I'm a practicing doctor and I see it with some people. Like, yeah, it's not the best for everybody all the time, but for some people, it really does work. And so I like that you're able to kind of, you know, understand the risks and the benefits at the same time and make really good decisions on an individual basis for what's going to work best for somebody. So I absolutely love that. I wonder if you could kind of update us on your clinic, how you're working with people, how that's changed over the years. Yeah, I'd love to hear about that. And especially like the 90 to 120 minute kind of time that you spend with people. You said it's a seminar. Is that like a group kind of a thing?
Yeah, so it's a shared medical visit. So I work at like a nonprofit hospital organization in Massachusetts. And basically the way that it's structured is it's me and a nurse practitioner who has her own weight loss story, who's very well versed in metabolic health and low carb, who follows it herself. And then I have a dietitian and an LPN and a medical assistant. And then we have like our front desk kind of checkout staff. So it's pretty small clinic, like in a big organization. So it's like this weight and wellness center in a bigger hospital organization. And what's nice about it is because I'm like the lead physician of this medical weight loss, they let me structure it the way that I wanted. And so what I chose to do is the very first visit when you come to meet me is a shared medical visit, like a group seminar that's between 90 and 120 minutes long, but the topics of discussion surround insulin resistance, metabolic dysfunction. We go over all of the laboratory values that your primary care physician has ordered, but then like what each one means. Like we're talking about hemoglobin A1C, but what it actually is, like glycosylated hemoglobin and what that average number looks like. I put everyone's A1C on the board anonymously and go through like where people lie on the spectrum of insulin resistance and how we're trying to stop the progression into type 2 diabetes. Then I get into like what insulin resistance is and how when people like us, including myself, I share my own story, consume sugar, carbs, and starch, we have a blood sugar spike followed by an insulin spike, and then our bodies start to get resistant to the effects of that insulin, requiring more of it to be released from the pancreas. And so I even go over like the USDA food pyramid and how bad diet advice has been taught for decades, and how like the modern standard American diet is like brought to you by Kellogg's basically. And then I go over low carb and how like we have to prioritize protein, fats, and fiber. I give example days of like eating low carb. And then I get into like, if you are going to follow any kind of tools, like low carbs, the base, if we're going to get into any tools like intermittent fasting or exercise or discussing like sleep, mental health, water intake, all of that is like in addition to diet. And then the last topic of discussion is like medications, like the good, the bad, and the ugly, and like what they constitute, how many people are going to be able to get on them, what insurance companies are even willing to cover them, and how we dose them and what the side effects are. And so it takes a long time, and people share their stories, which is really nice. Like I get to share my story so they know that I'm not like born this way. Like I was not born a thinner person. I like got here with hard work, and I'm like one of you. Like that's how I make it, very apparent that like I'm part of the struggle is part of who I am as well. And I think it helps for people to share their stories because then they know that they're being heard and that they know that they're not alone. It's usually like 10 to 12 people in a group. And then every appointment after that initial visit is one-on-one with me. And that's where we talk about what other tools we're going to add to low carb.
Got it. Wow, that sounds incredible. I spent the summer doing a weekly seminar series in my own neighborhood, teaching all of that kind of stuff, and I absolutely love it. So if there's ever a week that you can't make it, call me. I'll fly out to Boston and I'll teach it for you. I would love to do that. I love sharing that kind of stuff.
You
You're
ever
right.
come to Boston, you should come. You should just come, like you'll be a
I,
special
I
guest.
I would love to. Yeah, I would love to. That's fantastic. I love that you're doing that. I think that's a great way to connect with people. I love when you get the group together. Yes, everybody has their stories and they have inputs, and maybe some of them did do Atkins in the past, and they can talk about that, and everybody feels supported that way. I don't want to miss this. I think it's so interesting, and I think it can probably be taken for granted. But comparing your career trajectory before you found all this information and lost all this weight, going in to tell people what to do to lose weight, getting questions about weight loss when you're over 300 pounds versus what you do now, the way that you can share your story, literally put your arm around somebody and say, like, look, I've been there, I've done this. Like, you can do this. It must be just life changing. It must be the happiest thing. Like, your job satisfaction, your life satisfaction must just be through the roof.
Yeah, that's why I know that I'm doing what I'm meant to do. Like primary care was fulfilling and I felt like I was helping a lot of people, but it's like the insight is just invaluable. The way that I like know how these people are feeling sitting in this room. And I don't know everything going on in their life, but I know what having really severe life stressors is like, and I know what grief is like, and I know what, food addiction and binge eating disorder is like, and I know what it's like to have type 2 diabetes. So I can put myself in their shoes in a way that I could never do in primary care. And so like I think it's what I was meant to do.
Absolutely. It absolutely was. And I hope you continue doing it. It's been an awesome conversation. We haven't done an episode purely about weight loss in a long time. So I think this is going to be very helpful. Again, with all of these drugs and all the attention that they're getting, I think it's going to be really helpful for people. So, Kevin, this has been amazing. Where would you like people to go to find you and connect with you and your work?
So one of the things you mentioned when you introduced me was Fasting While Furious, which was my autobiographical book that I self-published a couple years back. But I actually have a new book, and it's based on all of my handouts that I give to patients. It's called Metabolic Health Handbook, A Doctor's Guide to Overcoming the Hormonal and Biological Barriers to Fat Loss. And it's available on Amazon in print, and you can also get it on Amazon Kindle, like an ebook, and on Etsy for download.
Wow, that's awesome. I didn't know that you were doing that. And if somebody wanted to work with you, is there a way to contact you, or just any like social media you want somebody to go to?
So my social media that I'm most active on is TikTok and Instagram. It's just at Kevin Gendreau. If someone lives in the Massachusetts or Rhode Island area, I'm licensed in both states and I practice in Brockton, Massachusetts.
Gotcha. Okay, awesome. Well, Dr. Kevin Gendreau, it was an amazing conversation. Like I said, it was great to meet you in person in San Diego, and I really hope you're able to make it next year. We're able to link up at some other conference. But until then, thank you so very much for all of your amazing work. Thank you for sharing your story, and thank you for coming on our show today to educate our listeners. We really appreciate you.
Thank you so much for having me. I appreciate it.
Absolutely, it was an honor. And this has been another episode of Boundless Body Radio.